Excellent. Good morning, everyone. I love that intro. I'd like to walk on to every event like that. So thank you very much, whoever was up there saying that. Welcome to this session. As you've already heard, we are here talking about integration. And our panel today are going to explore this question with a particular lens on the relationship between our mental health and our physical health. And I'm sure we will flow across a wide range of areas as we start to think about how we really bring together people's health and social care in a much more integrated way. I'm now 7 months into my new job as Chief Executive of Age UK, and I'm also nearly a year into my other role as a non-exec at Frimley ICS. So I'm very much exploring both those areas of new avenues and new experiences when it comes to thinking about how do we really respond effectively to the very significant needs of our older population in the time of a lot of change inside the system. And of course, why are we even thinking about this? Well, of course, we know that there's social and economic and organisational sense in thinking about how we bring together people's experiences. But the most important part of this is to think about, as we called it in this session, patient care. Although I think more accurately, we should be thinking about this in the context of citizen support, citizen care, as we help people to think about their health, not just now, but also into the future. And we know that certainly for older people over the last few years, that relationship between people's physical and mental health has been sorely tested. The long shadow of COVID in the context of older people's experiences is still very much with many, many older people. And I know from many of our local Age UKs who are still going to people's houses, knocking on doors, asking people if they'd like to come out, knowing that they haven't seen these people in their services since before COVID began, and the consequential loss of not just physical health in terms of people's conditioning and ability to do things, but also their loss of self-esteem and their loss of confidence has meant that it's really important for us to reach out to people and think about how we bring people back connected into services which help improve their health and well-being. So lots to talk about this morning, but fortunately a fantastic group of people to help us steer us through this issue. Marsha McAdam is the Vice Chair of the NHS Confederation Mental Health Network and Service User Representative. Kenny Lang is the Chief Nursing Officer of North Staffordshire Combined Healthcare NHS Trust and Deputy Chief Executive, so clinician and exec, very handy. Aruna Garcia is the GP Clinical Director for Leicester City and University's Primary Care Network. We won't be talking about Leicester City's relegation from the Premier League, I trust. And Sean Duggan, who almost certainly needs no introduction to this group, the Chief Executive of NHS Confederation's Mental Health Network. So welcome to all of you. Thank you very much for joining me this morning. Marsha, I want to start with you because this whole session is all about people's experience. Tell me a little bit about your experience of accessing health and care for your physical and your mental health. What's worked and what do you think could have been improved?
So I'm a survivor of suicide, well, multiple attempts, and I have both physical and mental health needs. And I had a diagnosis of borderline personality disorder, and from there I took multiple overdoses and my life was so chaotic. And in 2008 I took a near-fatal overdose that saw me in an induced coma for 3 weeks because I developed pneumonia, and then another week in hospital before I was sort of just shipped out. But I remember waking up and the whole in ICU, the whole of my right side of my body was in so much pain. And then, so I was just there, literally, they weaned me off the oxygen and that, just there for another few days and then out, kick out, go back. But it took that for me to then only be seen that actually because of the borderline personality disorder, she really does need support in that. So finally I was referred for mentalisation-based therapy that saved my life and changed me and saved me from myself. And that, so I had the tools to understand all the distressing things, but then I was left with this pain, physical pain. I have fibromyalgia, chronic fatigue, type 2 diabetes, non-alcoholic fatty liver disease, hemiplegic migraines, and a lot of other things. But I also now use a mobility scooter. I can walk short distances in that, but I can't stand up for more than a minute or so. So the mobility scooter gives me independence. But I also access social care for like my personal care, meal preps and medication prompts and that. And the carers, I call them my fairy godmothers because they sprinkle magic dust and that, and because I'd look like Medusa, you know, at home and that. But had I received early intervention all those years ago, I know that I wouldn't have gone on to experience all the, you know, the impact, the negative impact on my body, and that. So for me, it's about looking at, imagine if I got support all those years ago. My life trajectory could have been so different. But it's still, for me personally, I still don't see the parity of esteem. So yeah, for me, that's why I'm here for this conversation.
And it's fantastic to have you here, and having gone through all of that, all of those experiences. What do you think would have really helped right at the start in terms of, as you were developing your mental health challenges and your mental health issues, what would have helped from a physical health point of view, do you think?
Well, a few months ago I did a talk and I said, why don't people see all those overdoses over the years, the harm that it was doing to my body? You just sort of think, oh, they've overdosed, just refer them back to the GP and that. But imagine if I got talking therapies years ago, as opposed to just being seen as manipulative, attention-seeking, you know, all the stuff with borderline personality disorder. Imagine if I had those tools to understand all the distress. So that would have meant that maybe all the physical health stuff wouldn't have happened. So yeah.
Thank you. Kenny, your trust, outstanding rated trust in North Staffs, takes a whole person approach and joins up care. How do you do that?
Thanks, Paul. So, you know, as you'd expect, I'm a mental health nurse of a certain vintage, so you'd probably expect me to talk about health inequality, and for people with mental health, that is that they do face, and people with mental health conditions do face multiple disadvantage and multiple health inequalities. So I think in three ways, predominantly actually. So the first way really is ensuring that in strategic discussions and operational planning conversations across our integrated care system, that actually mental health is at the table, and those discussions are mindful of the needs of people with mental health conditions. That is really important because, you know, we all know how pressured the NHS is. In fact, all public services are. So there is always a risk that in times of pressure, people with health inequalities and people who may struggle with inequality of access are unwittingly often excluded from service provision, and we don't think about their needs in the way that we have to and should do. And so that's the first area I would say that is really important as a mental health provider, that we're at those discussions and we are championing and advocating for people with mental health needs. I think secondly, what I would pick up on is in terms of improving inequality of access. We are proactively designing our services to sit alongside partners who cater for the needs of people with mental health conditions. Now, that is not the sole duty of mental health providers. That is all services duties. We have to be able to be flexible. We have to be able to design our models to meet the needs of people with mental health conditions, learning disabilities. That's really important. So in a lot of our service provision, what we are trying to do, and in some cases quite successfully, is ensuring that we have mental health expertise, mental health interventions at the point that people access services. So having mental health practitioners in GP surgeries, in primary care settings, making sure we have mental health expertise in acute hospitals, so that those reasonable adjustments can be made, and so that design considerations are in place. One great example is our perinatal service, mental health service, who work very closely, obviously, with the local maternity services. And we've got some really good co-production in terms of recognising the needs of people who are using maternity services with mental health problems, and some really positive work about redesigning maternity suites, making sure we've got interventions for people who are using those services, and it's really, really powerful work, actually, and incredibly valuable. And then I think the third aspect really is about people who are using secondary mental health services, so specialist mental health services. How are we upskilling people with mental health professionals around their physical health care skills? So we're introducing advanced nursing roles as an example, people who have gone on and done higher education in physical health care skills, and making sure that they are teaching and using their skills to provide interventions around physical health. And then in community settings, physical health care clinics for people with severe and enduring mental health problems, because we know of the health inequalities and the reduced mortality of people with severe and enduring mental health problems. So I think there's three kind of levels there that I'd pick out, and all are really important, I think, for mental health providers to be focusing on.
Thank you. We'll come back to how we think about kind of describing that and evidencing it a bit later on, I think. But you talked about the importance of mental health in primary care, and Aruna, you're sort of, I suppose, you know how important primary care is from a mental health and, of course, a physical health point of view. As primary care evolves and changes in its nature, which it unquestionably is at the moment, what do you see as those sort of opportunities to really think about how we bring together the physical and mental health care of supporting our citizens?
Thank you. I think, and it's great to be here to have this conversation, actually, because being primary care, we recognise the importance of mental health and physical health in our populations. We're seeing more than ever post-pandemic. We're seeing greater burden within our adults, an increased prescription rate, our children and young people, an increased suicide rates, increased CAMS needs. So there's a real crisis of need almost in sitting in our populations. And I think one of the things is that was stark around COVID was the inequity of access to vaccinations that sat within our population with mental health, and the sort of the nuanced services that we needed to provide to make sure we levelled up those access to get those outcomes in terms of vaccinations. For example, sort of sensory clinics and working with our partners, etc. So there were opportunities that we found and discovered through partnership working, I think, through COVID. Not been helped. So, and I think just going back to the physical bit, we're talking a lot about mental health, and we recognise that post-pandemic there was sort of there were very, very low physical health check rates within our mental health population. So we were down to 20-30%. So it was really an example of just how easy it was to fall into inequity of access for our mental health patients. I think one of the problems with that is, as you were saying, it's severe mental illness. We only ever look at that, but actually in general practice we've got mild to moderate, and it doesn't tend to pick up those with significant impact on your working lives, like personality disorders, for example, fibromyalgia, chronic pain. So there's sections that we're not impacting on. And I think the third thing I just want to remember is the mental health that sits in physical health and comorbidity. Just let's not forget about that. So it's that bit of joining up and thinking about the whole person, not just within their context in society, but actually how they're presenting to each one of us as a professional or in our organisations. So with anybody with a long-term conditions, you've got 2 to 3 times more increased incidence of mental health, which will definitely impact on their outcomes, right? And you talked about those your outcomes and their life expectancy is reduced by preventable disease, so diabetes, for example, and cardiovascular disease, so real onus. That was a very long-winded way of getting around to what we think we could do. And I think that, primary care network, so I'm chair of the primary care network for the NHS Confed, so there's a little bit about what I've done in my own patch and a little bit about what is going on nationally. And primary care networks are working at the sort of 30 to 50,000 level with collaborations between, at the moment, it's general practice. And there is a real move to working at scale to help with resilience, workforce capabilities and partnership working to try and deliver some of those solutions. And I think it's really important that we don't look at it through the lens of a medical point of view, because that's always the danger in this space. We want to make sure it's co-created. So there is a move towards recognising the importance of whole person care, that bit of proactive, personalised, individual person care, not patient-centred, but person-centred, really important. And I think the bit about also working with an integrated neighbourhood team, so recognising that context of a person with physical and mental health needs, as we did in the pandemic, so working with breaking down barriers between the primary care, secondary care and community, so patients could flow between us, conversations could happen clinically and multidisciplinary teams could work. That is an aspiration. I'm not sure we're there yet, but I think we definitely recognise the importance of it. And there's something about working as an enhanced integrated neighbourhood team with social care, with voluntary care sector organisations, with communities, to really start to pull in community resources. And what we're hearing is that co-creation, so understanding that soft intelligence of communities or people that need help, that may not be presenting in the crisis that you mentioned at general practice or secondary care. And I think finally, just that if we go back to the integrated working and the partnership working, so that we can start to really tackle those wider determinants of health and get upstream, so we're preventing more. So and I think that's evolving as well. So primary care being in that space, negotiating and advocating for care for their patients, so that, with employment, with housing, with poverty, with even sort of diet, etc., it can really support our patients and our communities as we described. So I think, and there are pockets of examples across the country for all of those things I've described.
Well, perhaps we'll come to some of those examples in the conversation, and just to encourage all of you in the audience to think about the questions and contributions that you might want to make into the discussion. We have the Slido mechanism for you to do that if you like, but we'll also call on you to speak if that's okay. If you want to make a contribution, we'll be very much encouraging that in a moment, but not before we've heard from Sean. Now, Sean, you, I think without being at all rude to you, Sean, you have knocked around the mental health space for a while. And you'll have seen a lot of change in that time. And in fact, that whole question, Aruna's point about how we support the physical health of people with serious mental health problems, has been a really it's been a really key issue, hasn't it, for such a long time inside the mental health services. You've often kind of argued for the better join up between physical and mental health. So let's talk a little bit about what you see as those real concrete benefits are of creating that, rather than this having these kind of twin track of services. How do we make it much more single from a person's point of view?
Yeah, thank you, Paul. And it's I haven't made the adjustment yet that you're not in mental health, directly in mental health.
Well,
you are.
I think I am, really.
Yeah. And good morning, everybody. It's so good to have a session like this. You as you say, we've been trying to tackle this problem for quite some time. So, and there are other problems that come our way. So you think, well, but the interesting thing about the issue here is that we've never let this one go till we get it right. And wonderful organisations like Rethink Mental Illness, particularly on the severe mental illness side, will never let us forget how the core problem and the effects of the core problem that Marcia has outlined very well. I mean, I think from a sort of a strategic point of view, if we listened to and implemented what Marcia and Kenny and Aruna are saying, and we'll hear more about them in a minute, we'd go a long way. We'd fix the problem. But in order to do that, you've got to have the context, the environment right, and you've got to have the political will, and you've got to have everybody working in the same direction, which we haven't done in the past. But there's real hope, I think, and optimism for the future, and we will talk about integrated care systems, but look at it. It's on the tin, it's on the title, integration. We will look to integrated care systems. We will look to place to help us with this. So there really is a good opportunity to once for all put it right. But there's a lot of angles to it. But just to quickly rehearse the problem, the Centre for Mental Health, the King's Fund, and the London School of Economics a good few years ago, but it was a really good piece of work. It was saying that if you've got a long-term physical condition, you're 30% more likely to have a mental health problem, usually depression and anxiety, and if you've got a mental health condition, you're 46% more likely to have a long-term physical condition, and Marcia has explained to an extent what that's about. And then, of course, as I say, Rethink Mental Illness remind us on a regular basis that morbidity gap, particularly for people with severe mental illness, dying 20 years early. So that's why it is a session here, and that's why we still a long way from tackling it. I do think, from my point of view, before we get it back into the detail, that this is why, I mean, sometimes I think, are people hearing too much of us saying mental health is really a priority? Tackling ministers and Secretary of State later, mental health is a real priority, has to be a priority. You know, why aren't we talking as much about parity of esteem as we were a few years ago? It's good that National Audit Office say that we need to define what parity of esteem means, and the Department of Health and Social Care and NHS England will be working on that. That will be good reminders about parity of esteem and how far we are away from it. But if we don't keep talking about that and going to achieve that, then we can't tackle some of the stuff that you've talked about. You know, Kenny, I saw an advanced health practitioner the other day in a specialist mental health inpatient unit because there were a lot of complex physical disorders associated. And that was a brilliant thing. They only had one and they were just doing it, but fantastic. But in order to do that sort of thing, we need the NHS workforce plan, we need the investment. And I know things are tight at the moment, but that's why we articulate it in a certain way and in a positive way. I mean, there are the solutions. You know, that's a long way to the solutions. I think I'll end on, we were talking earlier, weren't we, about we set up systems. You know, we've got mental health trusts and we've got ICS and PCNs and we keep, you know, we change things around a little bit. It's great that we've got integration now that has to be a good model for the future. But we do have different organisations set up in different ways. The way to really tackle this is to significantly embrace the voluntary sector, social enterprise, community interest companies, because they do this. You know, that front end, they do the physical and mental health integrated work. But in order to do that, you've got to get organisations that have different operational ways of working, terms and conditions, etc. But when you look around, you see people, you see organisations keep finding a way through that. And it's brilliant when you do that. And it's all over the country. Really good ways of doing it. And we've got to scale that up. I think, I'll finish on this, I think what we need to do more of is, there are the solutions, we've got the blueprint, we've got some really good examples. How do we scale that up? That can be difficult. Is it that we can never do that because we've got integrated care systems, and when you look at one integrated care system, you've got one, so they're all going to be slightly different, and that's the way it's always going to be? But no, because we have got some really good, look at individual placement support, IPS, the mental health employment model. We've scaled that up, you know, so there are ways of doing it. Thanks, Paul.
Thanks very much, Sean. We'll come and talk about systems in a minute, but Marcia, you're very well networked across the people with lived experience. You know what people are saying at the moment. Where are the places where you think people get the right kind of help? Is it through, is it through primary care? Is it through secondary care? Or is it actually not about the system at all? It's all about the people?
So, firstly, I forgot to say before, it's actually nice to see so many people here. Mm-hmm. When I came by before, there was about 10 people, so I was like, oh my God. I'm also the Expert by Experience Chair for Equally Well UK, which we're looking at severe enduring mental illness and physical health. Many organisations are members in that. And it is to look at some of this, and as service users, we're sort of really concerned, about the food insecurity type thing. Last night, someone Dimbleby, what was he called? Henry Dimbleby was a speaker last night and talking about food and that. But what people don't, it's not just the food type thing. There's organisations like Deliveroo, Just Eat and that. So me, I would have a really bad thing of food, a relationship with food. So it's so easy, especially when you're disabled, to just click a button. And you don't even have to go downstairs to get your card details, because it's all there. Also, sadly, because of the cost of living crisis in that, it's sometimes a lot cheaper buying fizzy pop than a bottle of water, and so many other things. And I guess during COVID, Equally Well and a few others, they rethinking all that, fought hard to ensure that people with personality disorder were in the category of, but we weren't, in that. Sorry if I'm waffling. As the Expert by Experience Chair, I'm so sorry. As the Expert by Experience group, one of the things we're really worried about as well is that, how when you're on a ward and there's so much unhealthy food and everything like that, people don't actually think that. Also, if you're on a ward long term, one of the Experts by Experience, she was on medication, and she was given medication while she was on there that was doing her more harm than that. And it was only when she got really sick that they realised that. But she'd been on the ward quite a long time, and they don't it wasn't coming together.
So let's stick with that for a moment, and the impact, thank you, the impact of, in a way, the impact of the cost of living crisis, but also that wider environment that people are facing. I mean, Aruna, from your point of view, from a kind of, from primary care point of view, how is that playing into the day-to-day experiences of what GPs and other primary care practitioners are seeing? Is that changing what you're having to do, just because the world out there is so much tougher for so many people?
I think it impacts in different ways, doesn't it? So there's, first of all, people with existing illness that are our patients already. And we go back into those wider determinants of health, where if you have poverty, if you have insecurity of employment, if you have insecurity of home, etc. And if you're cold, you're going to end up having issues with how you present to the GPs, because sometimes with primary care, it can be the first port of call. It's almost the last custodian of support that's in the community. So we're definitely seeing, particularly over winter, I have to say, we definitely saw an increase in our older age long-term conditions. I think the second bit is the impact of cost of living and employment and mental health. So we can't forget, it's that bit of where you need personal safety, don't you? That reassurance and psychological safety within your community. So we saw our first incidence of mental health impacting. We'd just come out of COVID, so to be hit with cost of living on the back of that, I think we've seen our mental health rates go up. And then finally, I think we can't ever forget those secondary impacts. So they're just, people aren't individuals, they live in families and they live in communities. So if there's an impact of finance and an impact of mental health, you end up with things like safeguarding. You might end up with domestic violence, etc., that we saw definitely as an issue over COVID. So I think these secondary effects and being alerted to them were really important in general practice. So definitely and I think we'll end up feeling this for a few years to come, basically.
Yeah. Thank you. And Kenny, ICS is, of course, everybody, there'll be a lot of cake in a few weeks' time as ICSs celebrate their first birthdays. What do you see as being the differences? What's, for very, very young organisations, so much to do, very tough winter, as we've already heard, layered on with the cost of living crisis. What do you see what's your sort of, if you like, your judgment so far on how the mental health conversation is entering those systems, and also how do we make sure that it becomes absolutely hardwired into the discussions going forward?
Yeah, thanks, Paul. So, well, first of all, I'd say there's probably not likely to be much cake, given the efficiency challenges this year. But I think you're right. We are early on in the journey. I have to say, I'm quite hopeful. So, talking about Staffordshire's ICS and ICB, where obviously we provide services. I can see a lot of opportunity. So mental health and learning disability and autism, from my perspective, have got a seat at the table. There's clear portfolio of work that is happening across the system, which is really important. And I think, as we all know, relationships make the world go round, don't they? And so actually, in terms of our unitary authorities, in terms of working in partnership across the different providers, and of course the ICB, I see a lot of really good work happening. I think that will be accelerated as place evolves, moving forward as well, so we can really get into the I guess real detail about how we can make place work more effectively. But it's early. But again, I'm very hopeful. I think there is real good working, and I think the ambitions that are set out within ICSs are the right ones. Of course, I've already talked about health inequality, and we, again, are at the start of that. I think we've done some really good scoping, but I think we can really see a future which is hopeful.
Thanks. And Sean, the mental health community worked incredibly hard to ensure that there was a mental health person sitting around the table of every ICS. Early days, of course, but are you seeing that difference and in terms of how mental health is being considered in those ICS, ICB conversations?
Yeah, that was. I think it was really well worth us keeping and maintaining our position on that. I think if we hadn't, it wouldn't have been quite so evident. I think mental health such a priority in the ICS across the country. I could run, but I don't think I am. It's really, really helpful to have that. But a lot of them are chief executives of local mental health trusts sitting on integrated care board, and we thought it was important. We're going to need to have the discussion at place as well, because good mental health services means good physical health for people, and we have got lots of innovation and creativity and energy to make things right. There's fantastic leadership in the mental health world, and we had Sam Allen talking yesterday about mental health perspectives of the ICS, and there is a long way to go. I mean, and the Mind did a report recently about the capacity and the attention to mental health, and so there is still a long way to go. But having individuals, having mental health leaders there is a good thing. It can't stop there, though. We have to have people like Kenny and others getting involved, and I do think it's at the end of the day, it's about relationships and trust. So thank goodness we've moved away from, competition and all competing with each other, and we now have got a more equal playing field to all focus on the patient experience, which we're quite good at doing in mental health. So thank goodness we've got that, and we can have some real opportunities. And to have those good managerial relationships, but also good clinical relationships. I often think of young girls, predominantly, but boys too, very unwell in acute hospitals in the paediatric wards because of an eating disorder where they need real specialist mental health care. And the answer, of course, is partnership protocols with clinicians that relate well to each other and can provide that integrated service and have pathways into the community. And we have that throughout the system. There really is, that's why mental health is so incredibly important. And we all know that. But just to echo Marsha's point, I'm really grateful for so many of you to spend an hour in this. It's really good. And for those of you not in mental health, we're extremely grateful, and we need you. We were a bit disappointed a little while ago when government dropped the 10-year cross-government strategy. I'm drifting a little bit, but it's for the social, for mental health recovery. We need good employment opportunities. We need good accommodation, debt management, the right financial input, particularly now with the cost of living crisis. And that would have been a bit of a good the standoff at the moment with the Metropolitan Police in London around mental health, we do need everybody in on this and facing in the same direction. Not quite got that, but I think there is an opportunity to do so. And integrated care systems, they mature and develop, can lead it at a local level. But we as mental health leaders need to, as Sam Allen said yesterday, lean in, do our bit. And I think we're good at saying, look, these are the solutions. It's not banging the table saying we need more money. It's this, if we've got the solutions with lots of creativity and innovation, and here they are, here's the evidence, let's work together.
Great, very positive note. Let's open up to the audience. The only trouble being a chair here is I barely see people, but so if you stick your hand up and we will take a few. We've got a roving mic. Oh, that's great. We've got 4 already. So we'll start with the lady there. Then we'll go 2, 3, 4, and we'll take those all those comments in a row. We'll take 2, and then we'll ask the panel. Over to you.
Thanks very much.
say
Kate
who you are
Eisenstein from the Health Ombudsman.
Fantastic.
Really interesting discussion. Thank you so much. The panel's talked quite a bit about systems, structures, processes, which are absolutely essential. But I'm really interested in the culture and behaviour bit as well. And there's a clunky term, diagnostic overshadowing, which is very jargonistic. But I guess what I'm getting at is how, and Marsha, you touched on this, sometimes when someone presents with a mental health condition, that can affect how their physical health conditions are responded to, and vice versa. Someone with a physical health condition, as soon as their mental health is affected by that physical health condition, that can also affect their treatment. So that's a tough bit, isn't it? Behaviour and culture, because the rest of it's so easy. So I'd be really interested in the panel's reflection on that. Thank you.
Thank you. That's a great question. And we'll take the gentleman there if you're. As the mic's right next to you, we'll take you, and then we'll come there and there.
Okay, great. Hi, I'm Robert Ham. I'm General Manager at Kingston Hospital. And firstly, it's a great panel, so thank you for this discussion. And Marsha, thank you for sharing your story as well. I think that the way in which we spend a lot of time mapping access to physical care pathways, there's been a lot of talks already yesterday and today, is not well reflected in the same way for mental health pathways. We don't talk enough about how we're accessing mental health services. And running an A&E, I would actually say that I think in South West London we're in crisis in how we integrate physical and mental health in A&E departments. So a patient would, services would arrive in crisis. They would get signed off, in inverted commas, by EM consultants, and then referred to psychiatric liaison. At which point the care becomes completely disconnected. There are 2 people who are not working holistically, and it's such a shame. And then there's an 11-day wait for an inpatient bed, and those 11 days are often spent in a mental health assessment unit, MHAU, and I don't think we're talking enough about how access pathways for mental health care are broken, and we need to work together to fix them. Again, I'm hopeful. I think we recognise these problems and we can work together to fix them, but there's a long journey ahead. And there's been lots of discussions this morning about some of the talks yesterday and some of the positive spins that have been put on the progress we've made, and I think we've got to be really realistic about the challenges we still face.
Thank you. Let's join those two questions together. Kenny, is the problem in Kingston all to do with values and culture?
I suppose in part. So my experience would be that the example of the individual in distress in an accident and emergency department in ED is not untypical, is not unusual. I think the real importance is the connectivity between mental health providers, physical health providers. So, for example, well-resourced, Core 24 psychiatric liaison has got performance measures in the same way that all of other services would have, that you would expect in A&E, which is part of the solution. Having a well-resourced, well-managed liaison service is an important aspect. The other thing I would say, and I referred to it earlier on, I think, in my answer around access. Access is an incredibly important thing. It's something in mental health we have to be able to improve. We have to demystify the mental health system. So I think most members of the public would understand how probably GP surgeries work, how A&E services work. You ask someone, a member of the public, how mental health services work, they would probably look at you blankly and not understand it. So I think part of the work we've been doing in North Staffordshire is trying to improve that ease of access, so that actually, if someone is in mental health distress, they don't need to go to A&E. We've got an all-access 24/7 service where people can walk up without appointment 24 hours a day, 7 days a week, and ask for a mental health assessment. Now, there's lots of comms we're doing around that. We're trying to engage communities, but I still know there's parts of our local communities that don't know that. But that's really important, and I think that conversation that we have with certainly our local emergency practitioners is important as well, because actually there are alternatives there, and that doesn't mean people always going to A&E. Of course, they may have to. They may have comorbid needs, as we've talked about, physical and mental health. But again, it's important that they have both of those assessments in a really timely way. And we are fortunate, I guess, and I'll use that term, in that we don't locally have those challenges with bed access, but I am aware that nationally that is still a problem, and it's something that we need to address.
Thank you very much. Other panellists, any comment on either of those questions?
So I think I was just going to pick up on, so it's really interesting with access, because if you just take it to physical side, we have urgent care, don't we? But we're talking much more about personalised care, and we're talking much more about prevention and escalate and sort of trying to intervene early. So there's early intervention. I just wonder whether the conversation and culture needs to shift into that space a little, so that we understand why people are getting into a space where we need urgent access. So the access may be a little bit more about early detection, maybe a little bit more about personalised care and early intervention. And certainly within PCNs, there's a lot more work, because what I did mention was we have a number of roles now that are looking at personalised, proactive care. So we have our mental health practitioners, which you alluded to, so the increase in appointment availability for the more at risk, so that intermediate care. But more than that, we've actually got health facilitators and mental health OT, so that we're helping with those wider determinants of health and supporting those things that can that can trigger people into you were talking about sort of early access to counselling, weren't you, and your food and etc. So people with diet, obesity, sort of those kind of things. So in other words, I would be looking at it slightly differently, rather than thinking about the end point, but how can we intervene a lot earlier with those kind of interventions, break down the barriers so there's more fluidity, so people are getting to the right place at the right time. Clinical navigation in general practice, or a single point of access in a place would work with that. and then those ARRS roles, because we definitely have a much more enhanced INT that are sitting in primary care at the moment than I think, and it sounds like we need to make sure we've socialised that a bit more. But that's where place needs to come in.
Two really, really good questions. I think the culture one's really pertinent, and thank you for raising it. And we need to keep getting a handle on culture at all sorts of levels. And I think I quite like that. I very much like the term compassionate leadership style, and I do think, you know, I've seen a move from a real obsession with targets and money, and we've still got to meet the targets, and we've still got to work within financial envelopes. But there was a really quite an obsession around it, and what that created was you know, managing staff in the way that we do work within the finance. We do make the targets, and it was pretty full on. And with that, you got a raising of bullying and harassment. And of course, when you get that sort of culture, you know, forget the innovation, the creativity, and scaling things up, because we just retrench. We've made some really good moves and in the right direction. Victor Adewale yesterday reminded us, though, that with the NHS staff survey in particular, we've still got too many people leaving, still do have some bullying harassment, we still do have not enough positive culture. But I see on a daily basis leaders really working hard on that and putting staff well-being right at the core of it. To get good staff well-being, then we're more likely to achieve what we want to achieve. So I think compassionate leadership is a very good thing, and putting experts by experience, service users at the heart of what we do is really important. And so in some ways in mental health we're quite advanced with that when I look around the wider system, and I think in the acute sector, looking at that, you've got your own systems in place, but we can work together to make that work, because we need to do it now, not just as sort of a mental health perspective, but the whole patient perspective. On just one point on our friend from King's. Well, I mean, the bit you said at the end was that we know where we need to go and we will achieve it, but it's a long journey, and I understand that. I mean, you know, it's great that you're saying that, so you will find a way through. And as I say, another quote from Victor Adewale, he said at a conference a little while ago, if you want the answers, don't look up. You know, if you want to look, yes, of course NHS England have guidance and government will have guidance, but we know when you make things work, it happens at local level, and you will do it, but you need our help and support, which is why the context around investment and workforce is really important for you to be allowed to get on and do that, and we'll scale it up across the country. And when we're met with not being able to afford cake because of efficiency targets, these are real issues, so we need to try and, at a very difficult financial time in our cycle, we need to find ways through that.
Thanks. Marsha?
To do with cake, we need to go to caterers that are not going to charge so much more because of NHS. Sorry. So from my perspective, bearing in mind over the last few years, you're told don't go to A&E, don't go to your GP in that. And a few months ago, I was feeling really, really poorly, and I'd not seen my GP during COVID or that. And I went and I was quite poorly. I was anemic and everything like that. So there was all that, whereas I thought they're too overwhelmed, you know. Yeah, in the end, I was putting it all down to, it's just fibromyalgia, the chronic fatigue and that. But it floored me. So there was that sort of the comms, you know, that was coming out. And then, so I access social care, as I said before. And this cost of living thing, even though I'm still very actively using secondary mental health services and that, and I'm on benefits for my care, high rate care and high rate mobility, I still have to contribute towards service user contribution, you know, to the social care aspect. And I thought it was £80, it's gone up to £121.40 a week. So now, the reason I'm bringing this up, okay, because of cost of living, old people are using social care, aren't they? But in something last week on the news, on a programme that Age Concern was involved, it was on older people when they weren't eating or anything. and then they were ending up really
Yeah.
poorly. So my fear is, and I need to call it out, is I will have to choose between social care, paying that, or paying gas and electricity. So imagine how an older person will be feeling. They can't even, some of them weren't even having food for days and weren't putting heating on or anything. And the isolation, the woman, she was going to bed at 9 at night, but she was listening to the radio for company, and an old man, he was talking about buses and taxis and everything like that, and that breaks my heart. But by us not using social care, imagine them then falling, and then they hit A&E and they're in hospital for ages because they've broken their hip and that. And I think we need to sort of acknowledge that. So yeah, for me, that's something that I think we need to be honest about.
Thanks, Marcia, and I think that's absolutely right. I think my sense is, the ICSs were born in July. They immediately threw themselves, ended up being thrown into a winter, significant challenge for winter. And in a sense, the opportunity this year round is that we've got a bit more time to really think about how do we invest in that kind of prevention, upstream agenda, supporting older people. I mean, in my case, I'm in older people with mental health problems, people who need, affected by the cost of living crisis, to be able to have the ability to be able to have this appropriate help and support they need, so that they aren't going to necessarily turn up at A&E because they haven't got that help. So I think that's a really, really important point. Thank you. And certainly one of my observations about working in Frimley is the work that's taking place to build a different kind of culture actually inside that ICS, about between different practitioners, different groups, and particularly the primary care folk actually working really, really hard to think about, to bring those conversations into the middle of the discussion. Okay, we're going to open up for more questions. I promised 2 to start with, so we'll take that. The lady, yes, you there, and then right at the front, and then we'll go to you, sir. That's 3, so we'll take those 3, and then we'll see how we're doing for time.
Thanks very much. Rachel Surtees from UCL Partners. We're one of the AHSNs, and thank you to the panel. It's been a brilliant conversation, and particularly to Marcia for sharing your story. And if I have heard what you were saying properly, it sounds like what you needed early on was someone to bear witness to what you were experiencing and do something different. And if they had, then perhaps you would have avoided some of the subsequent physical health needs. But we also know that it's really painful for some people to see someone in deep mental distress. And so it's a kind of very similar veined question to the one earlier. On a really busy physical health hospital ward, when you're seeing something that you find really painful, I imagine it's really easy to look the other way and do the many other things that are on your list. And I wonder how you tackle that. So compassionate leadership, I'm sure, is part of it, but the kind of individual support for staff who are scared that they might make things worse, that are feeling the pain of seeing someone else in distress. Like, what's the answer to that bit of it, I suppose, is my question.
Thank you.
Thanks very much. That was, again, very interesting. So I'm Georgie, I'm a junior doctor, and I also work for a company called Fora Health, who work in shared decision-making and tracking of health and needs of patients. Going back to Marsha's point, and actually Aruna's point of earlier intervention, I think if we could identify people earlier and slightly take off that pressure from GPs at different touch points, like in secondary care, I think that would be quite useful. I wonder if there's any ways that that's currently done. So, for example, people on waiting lists, if we kind of screen them or ask them how their mental health is going, because I'm imagining a hugely long waiting list is a kind of another blow to your own health management. And then the second would be adding on 2 or 3 minutes to each secondary care appointment, just to ask, how are you doing, similar to what we do as, our ICE framework when you're in medical school. And just having those quick resources to refer people to mental health or social care help there and then might just really help take that pressure off different parts of the system. I just wonder whether anything like that exists already.
Excellent question, thank you.
Hi, my name's Chris Haig. I'm the Head of Meds Optimisation and Prescribing in Bolton Locality, which means I'm a pharmacist by background. We've done quite a lot of work to support the pharmacy workforce upskill in mental health, and with more and more services now going to either PCN pharmacy and community pharmacy, especially first contact, things like Pharmacy First and hypertension, how does the panel think we could look to upskill and incorporate and support the pharmacy workforce in delivering mental health and supporting that mental and physical health agenda?
Great, thank you very much indeed. I'll just very briefly come back to your question about how you support people in those early stages, and just simply because I saw a brilliant example in our local age UKs in West London, in Hillingdon and Ealing, where the local age UK is working alongside the acute hospital, working with older people who are on the wait list for mainly hip, knee operations, and they're going alongside those older, in this case, those older people, first of all, to check in on how they are, secondly, to help them be ready for an operation, and then thirdly, to provide extra help and support if either their physical or their mental health means that they can't get the kind of help they would normally need. It's a pilot. I'm really interested in it because I think it could really show a difference. And the primary, interestingly, the primary outcome from the Commissioner is whether people actually turn up to the operation. I think the primary outcome is how people feel about their own physical and mental health as they go on the journey. So I think there's something really interesting about what you can do to take people along that route, as even though we know it's going to be difficult. And just to kind of put that into perspective, somebody said to me the other day, I'm an older person, my operation has been delayed for another 6 months. My plan was to go on a walking holiday in the summer. That's gone. So these things just have an impact on people's lives. So thank you for asking that. Let's open up to any, if anybody would like to comment on any of those questions. Let's start with you, Sean.
Yeah, because I'd like to also just briefly talk about the early intervention, what help is around there. I think on the mental health side, that there is quite a lot, and I'd always say to people when they're faced with long waits and can't see the GP or whatever, get on the website, have a look at NHS England mental health web. It is very good. Have a look at Mind, Rethink Mental Illness, and for youngsters, Young Minds, absolutely brilliant resource. So there is so much there, and there is help available via these charities, and they're funded to help the local population, and we are working with them in a very big way. The voluntary sector also provides a range of crisis centres, drop-in centres. They can be very useful for people that, early intervention when they know that things are going wrong. And Marcia uses these systems rather well. And I'd also say there is funded by used to be clinical commissioning groups, but ICSs and primary care networks. There is a raft of good digital programs for people that like digital access to see a therapist online very quickly, no waits. It's quite good for helping the workforce as well. There are some accredited ones and recommended ones on the NHS website. They're very good, and the digital mental health solutions really are a huge part of the future. I can see it going at a really quick pace, and the NHS is trying to work with the companies that are doing the innovation and providing these wonderful platforms. So that's hopefully is helpful. I can't remember the question.
Don't worry, you haven't got time to answer it because you've only got 2.5 minutes left.
Yes, so I think a couple of things, if I can, and I'll come back to yours in a second because we've not forgotten you. So I think on building on this, the digital space is really important. So we've got, and it's a health and well-being approach. So don't forget that it's not just about online access to counselling, diagnosis, forums, etc. So lots of student work in that space, and online sort of counselling, like you mentioned. But there's actually that sort of behavioural approach with well-being and physical activity has been shown to really help with learning disabilities and autism. So I saw something yesterday with ADAS and AHSN, which was absolutely fantastic, co-created from ground up, etc. So I think there's lots of space for that sort of intervention. And just one thing, so community pharmacists and early intervention. So there's some work going on in Nottingham at the moment with community pharmacists actually intervening and signposting and doing some brief intervention with mental health. So it's happening in those contact spaces. Absolutely with pharmacists and upskilling for mental health. It's not just upskilling for mental health, but across the board in increasing workforce capabilities. And actually, we're going back again, that danger to splitting mental and physical health. Is it that we need to be combining them, as in ICE? Should there be an ICE-M, right, or something like that? So you're actually assessing not just physical activity and QALY, but you're assessing that within mental health as well. So I think there's just time in terms of credentialing that, because I think you're going to need that soon.
Kenny, you've got 25 seconds.
Yeah, I just did want to pick up the issue around people in distress, and that people perhaps aren't used to working with people in mental health distress. I think there is a really important role for, as I've talked about, mental health professionals that work in different healthcare settings. And I think, there are key issues, aren't there, around competency, capability, but also confidence. So I would say, if you're working in a non-mental health setting and working with mental health people with mental health challenges and illness, go and find those individuals that work in your areas, spend time with them, talk to them about helping you develop. And I know, having spoken to lots of practitioners that work in those different settings, that they do spend a lot of their time doing that, and I think it's really important that you have those relationships.
Last word, Marsha.
Equally Well UK, our members' physical and mental health checks, that's our priority, so check it out. Also, Crisis Point is what Sean's referring to, which is part of Turning Point. It's a short 7-day stay. It's really amazing, and I was there in January, February time, and Sean was amazed because I joined a virtual call in that, because they sort of really supported me, still trying to. So I want crisis points everywhere, and there's only 3 of that model. So for me, it's crisis points.
Brilliant. Thank you ever so much. Thank you for the audience for some fantastic questions. Lots of encouragement for all of us indeed to ask Steve Barclay a question about mental health when he comes along this afternoon. So please do that if you get the opportunity. Thank you for those questions. Thank you for the contributions of the panel. And just a little bit of sense for me about there's real hope here, even though times are incredibly tough. The challenge is how we knit all that together and really make that happen for people who are experiencing mental health problems across all ages. So please thank the panel, and thank you very much for your attendance.